Chapter 24 discusses disorders of white blood cells and lymphoid tissues. So the white blood cells and lymphoid tissues, where these cells originate and function, is to protect the body against invasion by foreign agents. Disorders of the white blood cells include things like leukopenia, in which there are deficiencies in leukocytes, and proliferative disorders, where we have an expansion of leukocytes. Proliferative disorders may be either reactive, that occur in things like infection, or they may be caused by neoplastic causes that we see in things like malignant lymphomas and leukemias. So we have two different types of hematopoietic tissues. We have the myeloid tissue, which consists of the bone marrow, and we also have the lymphoid tissue. So those are the various lymph nodes, which we'll talk about, as well as the thymus and the spleen. We won't talk much about the thymus in this unit. It'll come up a little bit more when we talk about immune function, especially kind of the acquired kind of immunities. But we will talk a little bit about the spleen today, especially when we start discussing some of the neoplastic disorders, because some of the signs and symptoms are related to the connection between the spleen as part of that lymphoid tissue. So we have many different types of leukocytes or white blood cells. The granulocytes, which consist of eosinophils, basophils, and neutrophils, and many of these obviously came up already when we were discussing the inflammatory response, because these are all involved in some way in the inflammatory response, often in different kind of numbers depending on what's causing the inflammation, but those are all different types of granulocytes. We also have the agranular monocytes or macrophages, and those are derived from the myeloid stem cells in the bone marrow, and they circulate in the blood. And then we also have lymphocytes. Those consist of T lymphocytes or T cells and B lymphocytes or B cells. And they originate from the lymphoid stem cells in the bone marrow, and they migrate between the blood and the lymphatic system. T lymphocytes mature in the thymus, and the B lymphocytes mature in the bone marrow. The T lymphocytes differentiate two different cell types called the CD4 plus helper T cells, which help to orchestrate immune response. And we're going to talk a lot more about the T and B lymphocytes and their function and some of the other units on immune cells. But the lymphocytes will come up today when we discuss some of the different types of leukemias. So this picture depicts the different kind of stages and products of hematopoiesis. So all hematopoietic precursors come from that pluripotent stem cell in the bone marrow. So that's what you see kind of way up here, meaning that's a pluripotent stem cell, so it can become any type of cell within the hematopoietic system. So it can become white blood cells, it can become erythrocytes, it can become platelets. And so that one cell differentiates into all those different types. So we call that a hematopoietic precursor coming from the stem cells. So again, these cells are capable of providing progenitor cells, or what we call parent cells, for myelopoiesis and lymphopoiesis. And so you see that here. So we have either lymphoid cells, stem cells, or myeloid stem cells. And those are kind of both branching off from that pluripotent stem cell. Processes by which myeloid and lymphoid cell, this is the process by which myeloid and lymphoid blood cells are produced. So then through several levels of differentiation, this leads to the development of what we call committed unipotent cells, which are the progenitors for each type of the different blood cell types. So if we have lymphoid stem cells, those branch off into these unipotent or parent cells of either, these are natural killer progenitor cells, these are T cell progenitors or beta cell progenitors. And so then these go on to create either NK cells, T cells, or B cells, okay? And then the myeloid stem cells, those branch off into either monocytes or granulocyte parent tissue or megakaryocyte or erythrocyte cells. And the monocytes and granulocytes produce the cell types you see here. Megakaryocytes become platelets and erythrocytes become red blood cells. So some notes about growth and production of white blood cells. Growth and reproduction of different stem cells are controlled by multiple hematopoietic growth factors or inducers. The lifespan of white blood cells is relatively short, so we do need constant renewal to be able to maintain normal blood levels of white counts. So any condition that decreases the availability of stem cells, those pluripotent stem cells, or conditions that would reduce those hematopoietic growth factors can produce a decrease in WBCs. And in addition to the growth factors that can induce white blood cell production, those growth factors are also supported by things like cytokines, like the interleukins. So identification of involved growth factors and cytokines that will induce white blood cell production has also led to to their use in things like treating diseases of the bone marrow or failure of some of those myeloproliferative disorders. So we actually can use or give growth factors or give different cytokines to help start this process off as a treatment for some of these disorders. So a little bit more about the lymphatic system itself. So the lymphatic system is made up of lymphatic vessels, lymphoid tissue, lymph nodes, the thymus, and the spleen. The lymphatic system is the site where B and T lymphocytes complete their final differentiation. And the lymph nodes are also the site of the origination of lymphomas, so one of our malignancies that we'll discuss. So some diseases of deficient blood cell production. So leukopenia is a decrease in the absolute number of leukocytes in the blood. And it can take the form of either neutropenia or granulocytopenia. Neutropenia is by far the most common type. Neutrophils constitute the majority of blood leukocytes, and they play that critical role in host defense mechanisms against infection. So if you remember, they migrate to the site of infection. They're responsible for engulfing and digesting and destroying microorganisms. So if we have someone with a decrease in the number of neutrophils or neutropenia, it places them at really high risk for infection. We had already talked about aplastic anemia a bit too when we talked about different types of anemia. But if you remember, aplastic anemia causes anemia, thrombocytopenia, and agranulocytosis. And so we'll see a deficiency in white blood cell production, but we also see deficiencies in red cells and platelets. So some common causes of neutropenia. There are congenital causes. Sometimes it's transfer of maternal antibodies that start to attack the white blood cells of the infant. There's also a disease called Costman syndrome, which is a genetic disorder that causes complete arrest in that myeloid or bone marrow maturation. Again, that's an inherited disorder, relatively uncommon. There are also autoimmune causes of neutropenia. They're usually secondary to disorders like lupus or something called Felty syndrome that we see in patients with rheumatoid arthritis. There are cases of what we call primary autoimmune, where the autoimmune destruction is just of the neutrophils themselves, but that's very rare. It's usually a secondary autoimmune cause. Infection can also cause neutropenia. Usually viruses are the cause of this, and they either decrease the production of neutrophils or they kill off neutrophils because they're releasing toxins. Or sometimes viruses will force neutrophils to remain kind of sequestered in the spleen, and so then they can't circulate. And so we see an overall reduction in neutrophil counts. Also, disorders like HIV can cause neutropenia. There are also drug-related causes of neutropenia, and you'll probably discuss some of these in your pharmacology course, or they'll be sort of pointed out as you get to them. But some of them are immune-mediated reactions, so things like penicillins, propylthiouracil, or amniopyrines are some examples of drugs that can cause immune-related destruction of neutrophils. Some drugs cause what we call accelerated apoptosis or accelerated planned death of neutrophils. So that reduces the overall neutrophil count. So things like clozapine, which is an antipsychotic agent, sometimes does that. And then also any drug that will suppress bone marrow function overall. So the common thing there is chemotherapy agents. Other causes of neutropenia, if you have extensive radiation treatments to the bone marrow, or hematologic malignancies, and we'll be discussing many of these coming up. So some other signs and symptoms of neutropenia. So they're often those of bacterial or fungal infections that become kind of overwhelming or more common. So things like malaise, chills, fever, weakness, and fatigue. We'll also talk about some of the white blood cell counts that we see. So one of the definitive ways that we look for neutropenia is something called an absolute neutrophil count. And that's this came directly from your book. It's a way that we calculate the ANC. So a normal ANC or absolute neutrophil count is about 1,000. If the ANC is less than 500, we consider that person to be very neutropenic, and we would put them on what we call neutropenic precautions in the hospital to protect them from the environment because they're at such high risk of infection. The equation accounts for segs, bands, and total WBCs. Segs are mature neutrophils and bands are immature neutrophils. So we're taking into account both the presence of fully mature and maturing white blood cells in here. Okay. Let's see, neutropenia itself, though, refers to abnormally low levels of neutrophils. And so usually it's defined as a circulating neutrophil count of less than 1,000. The term agranulocytosis means a virtual absence of neutrophils. So this slide just kind of shows a kind of case of how to calculate an absolute neutrophil count. So if our patient JD is a 42-year-old with progressive fatigue, on exam they have splenomegaly and lymphadenopathy. So you guys will see what that means in a little bit here. And the CBC or complete blood cell counts are listed here. So white blood cell counts of 1.2, and then we have percentage of total neutrophils as 70.1, and we have bands as 3%. And so that neutrophil percentage, those are our segs, and then the percentage of bands is our bands. And then the WBCs are that 1.2, or what we're going to convert to 1,200. So our ANC count, WBCs times cells times the percent of mature mature neutrophils and bands. So we're going to do 1,200 because that's our total WBCs times 70.1 plus 3 divided by 100. So this patient's ANC count is 877.2. So this patient is above that 500, so they wouldn't need neutropenic precautions, but they are below 1,000, so they do have some level of neutropenia. Okay, so I put this in here to show that when we talk about bands and segs, we're talking about them in a percentage. And that's why you're seeing kind of this 100 number to remove the percentage. Okay. So some neoplastic disorders of the hematopoietic and lymphoid tissues. So these represent the most important of the white blood cell disorders, and they include several different categories that overlap in several several ways. So we have our lymphomas, and those are Hodgkin's and non-Hodgkin's lymphomas. We have our leukemias, and we'll talk about the plasma cell dyscrasia of multiple myeloma. So we're going to start with the malignant lymphomas. So this is a diverse group, this should say, of solid tumors composed of lymphoid cells. So remember, the lymphoid cells were really kind of those B and T cells, okay? So we're going to start with non-Hodgkin's lymphomas, and these are things like B cell lymphomas. There's also something called Burkitt lymphoma, which is largely caused by viral infections like Epstein-Barr. Not a very common lymphoma that we see in the US, but places in Africa, other countries are, many countries in Africa, we do see high levels of Burkitt lymphoma. And then there's Hodgkin's lymphoma, which is a specialized form of lymphoma. So we're going to start with some categorization of the non-Hodgkin's type lymphomas. So there's low-grade lymphomas, and those are predominantly B cell tumors. There's intermediate grade lymphomas, and those can include both B cell and T cell lymphomas. And then there's high-grade lymphomas, and so those are largely immunoblastic B cell, lymphoblastic T cell. That includes both Burkitt and non-Burkitt lymphomas. So low-grade lymphomas may progress to more kind of aggressive types, but they're usually present with painless lymphadenopathy that's either isolated or widespread. So it's also important to understand and look at some of the staging of non-Hodgkin's lymphomas as well as Hodgkin's lymphomas, because this largely speaks to how well we'll be able to treat these diseases. So we use the Ann Arbor classification system to stage lymphomas. So we have stage 1, 2, 3, and 4. And then we also have A and B categories within those stages. So those in classification A generally have no symptoms, and in B they have some kind of symptoms. Generally, those symptoms look like things like fever, night sweats, and weight loss. A stage 1 lymphoma will have a single lymph node involvement on one side of the diaphragm. In stage 2, there are multiple sites of lymph node involvement, but we still remain on one side of the diaphragm. In stage 2, there are multiple lymph node involvement sites, and they're occurring on both sides of the diaphragm. And in stage 4, we have multiple lymph node sites, both sides of the diaphragm, but now we're also starting to see infiltration into other tissues, so things like other organs or potentially into the bone. So diagnosis of non-Hodgkin's lymphoma is usually done by things like history and physical. So we're looking for things like enlarged lymph nodes. We might look for things like enlarged spleen. We might look at different risk factors for lymphomas. And then we would do a biopsy of those lymph nodes to look for abnormal cells. And we may do bone marrow biopsies as well to see kind of the extent of spread if we've had spread of these cells into the bone marrow. We can also do multiple blood studies, things like CBCs or other types of chemistry. We can do chest and abdominal CT scans to look for changes or involvement in lymph nodes throughout the body, and other kind of imaging studies like MRIs, PET scans, and bone scans to help us determine spread of these diseases. So Hodgkin's lymphomas are a specific subset of lymphomas that are characterized specifically by the presence of abnormal cells called Reed-Sternberg cells. So when we're doing definitive diagnosis for Hodgkin's lymphoma, what we're looking for are these specific cell types called Reed-Sternberg cells. And there are some pictures of what those look like in your reading, but it's a very specific cytology target that we're looking for with Hodgkin lymphoma. This type of lymphoma usually occurs either in early adulthood, so I think between the ages of like 15 and 40, or in late adulthood, so after the ages of 55 are the most common types. Etiology or cause is really unknown, although it's probably a mix of genetic causes with exposure to some kind of carcinogen or viral exposure. So symptoms of Hodgkin's lymphoma. So in stage A of Hodgkin's lymphoma, there's usually no constitutional symptoms at all. There may be some enlarged lymph nodes if the patient even notices them, but they're usually painless. Really nothing showing up there. Um, Sometimes we may discover Hodgkin's lymphoma too on just routine chest x-ray for something else, and we may note like a mediastinal mass. Sometimes for those with um, more advanced or enlarged mediastinal masses, we may see things like chest discomfort, cough, or dyspnea. A mediastinal mass is a mass that's kind of right in the midline of the body, kind of right near the sternum. And so that's why you're seeing chest discomfort, cough, or dyspnea in those patients, because it's kind of pressing on maybe the lung tissue and in the structures kind of right around in the chest. In stage B Hodgkin's lymphoma, and this is about 40% of cases, we might see things like significant weight loss, fevers, itching, night sweats. They'll probably become more susceptible to things like infection. And then in advanced stages, these patients experience fatigue and anemia, and these signs indicate really a more, a more accelerated disease spread. And then there can also be involvement of the liver, lungs, digestive tract, and central nervous system. If this is treated early, the 5-year survival rates are well over 90%. So this is very treatable. And so you can kind of see here too how the different kind of risk factors and things that we're seeing relate to the different stages and symptomatology, and also relate to how easily we can treat this disease. So again, diagnosis is really based on the presence of those Reed-Sternberg cells on biopsy. We can also do computed tomography or CT scans, and what we're looking for there is chest and the abdomen to look for involvement of mediastinal masses or abdominal or pelvic lymph nodes. There's something called a bipedal lymphangiogram, and that can be used to detect really small, kind of minute structural changes in the lymph node that are often too small to even visualize on CT scan. We can use PET scan imaging. We can do bone marrow biopsies to see if the disease has kind of disseminated into the bone marrow. Hodgkin's lymphoma, as far as treatment, it really is one of the most curable cancers. It typically has a much better outlook than our non-Hodgkin's lymphomas. And the 5-year survival rate for Hodgkin's is 85%, 10-year is 80. For non-Hodgkin's, the overall 5 and 10-year survival rates are 69 and 59% respectively. So we do much better with treatment for Hodgkin's lymphoma than NHL. But the treatment for both Hodgkin's and non-Hodgkin's depends on the type of lymphoma. It also depends on the stage of the disease at diagnosis and the overall clinical status of the person, really how healthy and how able they are to withstand treatment. And so it might be different types or combinations of therapy, things like radiation and chemotherapies. For non-Hodgkin's lymphoma, we might use adjuvant radiation therapies, so maybe more small dose therapies, or there are some what we call monoclonal antibody treatments that are sometimes helpful. So next we'll talk about the leukemias. So the leukemias are a group of malignant neoplasms that arise from the transformation of a single blood cell line derived from the hematopoietic stem cells. And so we can classify leukemias as either according to their cell lineage or according to acute versus chronic diseases. And when we talk about classification by cell lineage, they're either lymphocytic or myelocytic, meaning they either come from the lymphocytes, so those are those B and T cells, or they come from the myelocytic sites, so granulocytes or monocytes. So the lymphocytic leukemias involve immature lymphocytes and their progenitors that are originating in the bone marrow, but they can then infiltrate the spleen, the lymph nodes, the CNS, and other tissues. So again, immature lymphocytes, so immature, usually B cells and T cells. The myelogenous leukemias involve the pluripotent myeloid cells in the bone marrow, and those leukemias interfere with the maturation or the maturing of all blood cells, including the granulocytes, the erythrocytes, and the thrombocytes. So the myelocytic leukemias involve many different cell types beyond just involvement of WBCs. And again, acute versus chronic, and we'll talk about both types. So the etiologies and biology of the leukemias. So your reading says the causes are largely unknown. However, then they go on to talk about a lot of different things that are associated or seem to increase risk or likelihood of developing leukemia. So one is that we see extremely high rates of leukemias develop in people who are exposed to really high levels of radiation. So we're talking like people in Hiroshima post atomic bomb, really high levels of leukemia formation. So these are not just your run-of-the-mill doses of radiation that you might get in diagnostic x-rays. These are extraordinarily high doses of radiation. And we also see increased rates of leukemias in people who have been exposed to maybe different benzenes, which is a chemical, certain drugs, certain, there's other, categories of chemicals that seem to increase likelihood, certain gases. So there are some causes that we know of, but most cases that we see in leukemia, we don't necessarily have a connection to some of these different exposures. There's also seems to be a genetic predisposition as well, as we see increased familial rates. But whatever event causes leukemia to form, it seems to lead to this dysregulation of genes that are responsible for regulating blood cell development and homeostasis. And so, normally there's a certain regulation mechanism that should control, the growth and production and planned death of these cells. And in the cases of leukemia, those genes that should regulate that process seem to not be functioning in a normal way. So, in acute leukemias, and we'll contrast that to chronic leukemias that we'll talk about in a moment, we have kind of two different types. We have acute lymphocytic or lymphoblastic leukemia, and that's ALL, and we also have acute myelogenous or myeloblastic leukemia. So in lymphocytic leukemias, we're talking about immature lymphocytes. They're progenitors in the bone marrow, and also involvement in the spleen, lymph node, CNS. So again, lymphocytes, those are your T and B cells that are coming from that lymphoid tissue. ALL is common in kids. And then AML, which we'll talk about next, is more common in adults. AML is acute myelogenous or myeloblastic leukemia, and that involves the pluripotent myeloid stem cells in the bone marrow. And so that's going to interfere again with the maturation of all blood cells. AMLs are usually associated with more acquired genetic alterations. So some hallmarks or some characteristics that we see in leukemic cells, the cells themselves are immature and poorly differentiated. They proliferate much more rapidly than normal white blood cells, and they have a much longer lifespan. So again, when we talk about that dysregulation, the regulation of how often we should produce them and how soon they should die seems to be completely interrupted. And so they're growing really rapidly, and the older cells are not dying off as readily. And so you just have this overall kind of massive increased production in those cells in general. They also interfere with the maturation of normal blood cells. The leukemic cells will go and circulate in the bloodstream, so we can do serum tests and find these cells circulating in the bloodstream. They can also cross the blood-brain barrier, which is why we can see things like CNS involvement in leukemias. and they can also infiltrate into many body organs. So again, we see a lot of involvement of things like liver and other tissues in leukemia because of that ability of those leukemic cells to infiltrate tissues. So even though ALL and AML are distinct disorders, when we look at clinical manifestations, they're often very similar. Both of them really have kind of a typical abrupt onset of conditions as well. And so some of the overall signs that we see are things like fatigue, pallor, weight loss. They will have repeated infections. They can bruise easily and get nosebleeds and other types of hemorrhage. Remembering that this disorder doesn't just may not just affect the white blood cells, it can affect all cell types. And they may also experience bone pain, and that bone pain is directly coming from that increased production of cells within the bone marrow. There are also some complications that can happen. There's a condition called leukostasis, and this happens from what we call an increase in of circulating blasts. And blasts are those immature leukocytes that are starting to proliferate and increase in number in the bloodstream. And so that circulating blast count becomes so elevated, it starts to increase the viscosity or the thickness of the blood itself. And that can form what we call leukoblastic emboli. So remember, emboli are thrombi that are now traveling. So they're little kind of, um, emboli that can start to lodge themselves into small vessels and occlude them. And so we see different small vessel occlusions in the pulmonary circulation, and we also see it in the cerebral circulation. So if it's in the pulmonary circulation, your patient might develop things like shortness of breath or dyspnea. They might be hypoxic. If it's in the cerebral circulation, you might see signs and symptoms that are similar to stroke, like weakness, hemiplegia. You might see changes to speech, confusion, all from this leukostasis. Tumor lysis syndrome is a condition that can lead to like life-threatening metabolic disorders. And this is usually something that's happening during treatment for those diseases where someone is receiving things like chemotherapy, and it causes a massive kind of like breakdown of cells and release of their contents. And when that happens, you can get things like severe hyperkalemia, hyperphosphatemia, hyperuricemia, hypomagnesemia, hypocalcemia, and acidosis. Those are kind of the hallmarks of tumor lysis syndrome. Leukemias are not the only cancer where we can see tumor lysis syndrome. It can happen in many different forms of cancer, especially again during chemotherapy treatment where we have kind of this massive like breakdown of cellular components as those tumors start to kind of die off. It can cause things like acute renal failure and other significant signs and symptoms. Hyperuricemia is also something that can develop kind of on its own. As those leukemic cells start to die off from chemotherapy, they release something called purines into the body, which causes this, again, hyperuricemia, which is an elevation in uric acid in the blood. So diagnosis and treatment of leukemia. So demonstration of leukemic cells in the peripheral blood and bone marrow is really definitive for the diagnosis of leukemia. So we do blood and bone marrow studies, and we're looking for the presence of those immature white blood cells or blasts. Treatment happens in three distinct phases. So there's what we call induction therapy, where we are attempting to elicit what we call remission in these patients. And we'll talk about what constitutes remission here in a moment. The next phase is something called intensification therapy. And this is used to produce a further reduction in leukemic cells after we achieve remission. So there are certain numbers of leukemic cells we look for to say, yes, we're in remission. And then we move into the next phase, or this intensification phase, where our goal is to drive down the numbers of those leukemic cells even further. Okay. And then in maintenance therapy, we are working to just maintain that stage of remission. Okay. Um, all staging of these diseases could also include things like lumbar puncture, where we're looking for things like CNS involvement. Other diagnostic things we might use to look for, staging and involvement are things like CT imaging of the chest, abdomen, and pelvis to look for additional sites of disease. If the three-phased kind of treatment to get us into remission is not successful, bone marrow transplant can be used for those who failed other types of treatments. So these are the criteria to determine whether or not we're in remission of ALL and AML. So what we want to see is that we have less than 5% blasts in the bone marrow, so a very low count of those immature white blood cells. And we also want normal peripheral blood counts. So when we do something like a serum CBC, we want those counts to be normal. And we also want to see if we do cytology to look at those cells, we want to see an absence of cytogenic abnormalities. So we want to see normal differentiation of those cells. And we want the person to clinically return to pre-illness performance status. So some of those other clinical manifestations, like things like weakness and fatigue and night sweats and all those things we listed, we want to see those things kind of become absent in that patient. And there are different factors that will determine whether or not there's a good likelihood of someone achieving remission in leukemia. Age is the most significant prognostic variable. The very young and the very old are probably people we're going to have the most difficulty getting into remission, especially older patients. The chance of remission in much older patients is far less. It also can depend on the type of leukemia. And it definitely depends on the stage of the disease at time of presentation. So the more advanced the leukemia, the more difficult it will be to attain remission in these patients. And so now we're going to move on from the acute leukemias to the chronic leukemias. So the definition, these are malignancies involving the proliferation of well-differentiated myeloid and lymphoid cells. So remember that in acute leukemias, we had, poorly differentiated myeloid and lymphoid cells. And so in this case, these cells remain pretty well differentiated, meaning they still look pretty much like the cells that they started from, okay? These are typically seen in older adults, not in children. And there are, just like with acute leukemia, there are two types. We have the chronic lymphocytic leukemia, and we have chronic myelogenous leukemia. So we're going to start with chronic lymphocytic leukemia. So these are malignancies of beta lymphocytes, and these are the most common form of leukemia that we see of all types. Many forms of chronic lymphocytic leukemia, or CLL, are what we call indolent, meaning that they are very slow growing. People really don't show much for outward signs and symptoms. Sometimes we come upon this just really, we're testing for something else and we just happen to find this as a secondary finding. Many people with these forms of kind of indolent CLL survive for many years, often without any sort of therapy, and they often succumb to some other unrelated disease before the CLL would lead to any sort of mortality. Indolent forms show up as increased leukocytes, usually found during some kind of other unrelated screening. But there are some people who are initially diagnosed with much more aggressive forms, and these patients might require things like bone marrow destruction and stem cell transplant to cure the disease. So people with aggressive forms of CLL experience a much more rapid sequence of clinical deterioration. So it's characterized by significant lymphadenopathy, hepatosplenomegaly, so enlarged liver and spleen. They experience signs and symptoms like fever and abdominal pain, significant weight loss. They also get progressive anemia and thrombocytopenia, and they have a really rapid and significant rise in their lymphocyte counts. The other type of chronic leukemia is chronic myelogenous leukemia. So this is a disorder of the pluripotent hematopoietic progenitor cells. So this, just like in acute forms, is going to affect things coming from the bone marrow of all cell types, right? So, this is characterized by excessive proliferation of marrow granulocytes, as well as erythroid or red blood cell precursors and megakaryocytes, so the cells that eventually form things like platelets. Um, there's a kind of a three-stage clinical course typically to CML. The first stage is the chronic phase, and this is a variable length. Again, some people live with this for just years and years with no symptoms, and some go through this chronic stage much more quickly. So there's a lot of variability in how long someone would stay in this chronic phase, but it's slow developing. There's a lot of maybe non-specific symptoms, maybe some weakness, maybe some weight loss. They do have leukocytosis and the presence of immature granulocytes. So if we look at their serum, both of those things would be present. They also typically develop anemia and thrombocytopenia and some degree of splenomegaly or enlarged spleen. The next phase is the short accelerated phase, and we say short because this phase typically would only last about 6 to 12 months. And in this phase, we see further enlargement of the spleen, and that enlargement can start to cause things like abdominal fullness and discomfort. They also have a rapidly increasing basophil count and far more immature cells in their blood, and now also in the bone marrow. And then they develop more clinical manifestations as well during this phase, things like fever and night sweats, bone pain, more extensive weight loss. They also can experience bleeding and bruising from the loss of things like platelets. Um, so, more symptomatology in that short accelerated phase. And the final phase is what we call the terminal blast crisis. And so this is when that chronic CML evolves into acute forms of leukemia. So many, many more blast cells, rapid proliferation of those blast cells. There is an even more significant increase in the size of the spleen, so increased splenomegaly. And then we see infiltration of these leukemic cells into the skin, into the lymph nodes, into the bones, into the CNS, very similar to what we see in AML at this point. Okay. So goals of treatment for CML. So we want to see a hematological response that looks like normalized blood counts. So when we take a CBC, we want to see those blood cells normalize. We also want to see what we call a cytogenic response. There is in patients with CML, we see the presence of something called a PH chromosome in the bone marrow. And so if our treatment for CML is working, we would see a reduction or elimination in that PH chromosome. And finally, we want to see what we call a molecular response. And so that would be the elimination of what we call BCR ABL fusion proteins. These are proteins seen with the proliferation of cell types in CML. Okay. Curative treatment for CML is allogenic bone marrow or stem cell transplantation. And the final malignancy we're going to talk about is multiple myeloma. So multiple myeloma is a cancer that forms in antibody-producing plasma cells. So in multiple myeloma, cancerous plasma cells start to build up within the bone marrow. So the main sites in the body involved in multiple myeloma are the bones and bone marrow. We also see this proliferation and overall activation of osteoclasts. And so we see an increase in bone resorption and destruction in patients with multiple myeloma. And so they develop things like pathologic fractures and hypercalcemia in response to that. So a little bit more about the clinical manifestations. So again, the main sites involved in multiple myeloma are the bone and bone marrow. So we see bone marrow infiltration. They get things like thrombocytopenia or purpura because this is disrupting the bone marrow production of things like platelets. They can also get anemia, leading to fatigue and pallor. They get neutropenia, so they're susceptible to infection. Again, all of that has to do with the proliferation of those cells into the bone marrow. They get increased osteoclast activity, so they can get things like bone resorption and destruction. So that leads to things like bone pain and pathologic fractures and hypercalcemia. They fail to produce antibodies, so they get things like recurrent infections. They get hypersecretion of plasma, or the hypersecretion of paraproteins from the plasma cells. And this causes this increased viscosity of body fluids. And then we get what we call amyloid deposits in the heart and the kidneys. And so these patients can also develop things like heart failure and renal failure from the depositing of these amyloid tissues. And finally, diagnosis and treatment of multiple myeloma. Diagnosis is often based on maybe looking for some of those clinical manifestations that we discussed, but also looking at blood tests and bone marrow exams. We can also look at bone radiographs. Anemia is essentially universal, so we should see anemia on blood testing. We also really commonly see things like hypercalcemia and elevated erythrocyte sedimentation rates. We also might be looking for different signs of kidney failure, so looking at maybe BUN and creatinine, glomerular filtration rates, some of those other kidney markers. High dose chemotherapy with autologous or same person stem cell transplant is considered appropriate frontline therapy for people younger than 70. So for this disorder, that may be our first type of treatment that we would use for this disease.